So the next presenter is Jason Wong. He received his bachelor's degree in electrical engineering at the University of Alberta in 2018. Currently, he is pursuing a PhD in computer engineering at the University of Alberta. His research interest is in machine learning and its application in biomedical fields. The paper he will present is titled Fully Automatic Axial Vertebral Rotation Measurement of Children with Scoliosis using Convolutional Neural Networks. Okay.
All right, thank you for the introduction and hello everybody. I'd like to thank MyCat for giving me the opportunity to present my research, which focuses on adolescent idiopathic scoliosis, or AIS. And so AIS is a three-dimensional spinal disorder where the spine is characterized by lateral curvature in both the coronal and the sagittal plane, as well as individual axial vertebral rotation. This affects 1 to 3% of adolescents aged 10 to 16 years old, and if left untreated, it can cause some problems, including back pain and cardiopulmonary compromise. Now, one of the more prominent features of AIS is the lateral curvature severity in the coronal plane here, because it determines how we prescribe certain treatments for children with AIS. So we will actually be looking into axial vertebral rotation, or AVR, and this tells us how much a given vertebra is rotated along its axis. Now, there are two main uses for AVR. The first being that there's evidence that it is predictive of curve progression. Curve progression being whether a patient's curve severity will worsen within their next clinical visits. And so accurate curve progression prediction is widely sought by clinicians because if we can predict that a patient will progress, then we can initiate treatment sooner, therefore increasing the effectiveness of the treatment and therefore improving the health outcomes for the patients. The other main use is for surgical planning. So for surgery, surgeons need a general idea of how to insert the screws into the vertebra and the optimal angle for that. And so incorrectly evaluating the AVR can increase the risk of pedicle breaches and therefore the risk of surgical complications for the patient as well. Now, in terms of measuring the AVR on a PA radiograph, we typically use Stokes method. And so that consists of identifying the centers of the pedicles being these ellipses on the left and right of the vertebra here, and also identifying the center of the minimum width of the vertebral body. And so once we identify these 3 points indicated by the green X's there, we can then plug in those parameters into our Stokes method formula and get a rotation angle. Now, the issue with this measurement method is that it is difficult and time-consuming to measure. Difficult because in many cases for a vertebra, one pedicle is occluded on the X-ray, making measurement error quite high, and time-consuming because there can be up to 13 relevant vertebrae to measure for spine. And so identifying these 3 points and doing those calculations for all 13 can really add up and be a measurement burden for clinicians. And so this really raises the question, can we automate this measurement procedure to really alleviate that measurement burden? And so in terms of related literature, there are 2 groups that have automated steps of it, but in the end, the clinicians would still need to manually identify certain spinal features. Now, our group actually has developed a fully automatic method, but it currently only works for X-rays taken by the EOS system. The EOS system being a newer form of X-ray that offers a lower dosage of radiation. The issue is that some centers still use the conventional system or the older X-ray system. And so really what we want is an automated method that can work on both systems so that all centers can reap the benefits of automatic AVR measurements. And so that brings me to the objectives of our study, which are to develop a fully automatic AVR measurement algorithm that can measure on both systems and to determine the accuracy and validity of this proposed automatic measurement method. So moving on to our methods, I'll go over a brief algorithm overview, and I'll go over the individual details later on. So our first step is to get the region of interest, which consists of segmenting the spinal column from the T1 to the L5 vertebra. We then move on to isolating the vertebral body and pedicles, which consist of segmenting them on square images of the same vertebral body, and then performing what we call iterative location of the vertebral body, which merely consists of separating them from the spinal column. We then move on to correcting and measuring, which consists of performing image registration to correct the vertebral body segmentations. And then from there, we have the necessary information to calculate our AVR. Right, so our first step is spinal column segmentation. And so given an initial PA radiograph taken straight from clinic, we first process it using histovariant equalization to accentuate the vertebral boundaries. And then we segment it using a convolutional neural network, which we call CNNSC. We also perform post-processing to get the spinal column curve, or the SCC, which is just this lime green curve in the middle of the rightmost image here. And you'll see that we'll use this in a later step. Now, I mentioned that we use a CNN, and so you're all familiar with that architecture at this point. It's the UNet. The figure of it is on the right here, with an input image size of 256 by 128. Our data set consisted of 96 training and 14 validation images, and we split that between half conventional and half EOS images, just so that our algorithm wasn't biased towards one system over the other. And to increase the effective size of our training sets, we employ data augmentation of flipping and rotation. Now, next up is virtual body segmentation. And so given a square image of the virtual body, we process it and we segment it using another CNN, which we will call CNN-DB, and it also uses a unit architecture. Our data set is 272 to 68 training validation splits. And for data augmentation, we perform flipping, rotation, as well as zooming and translation. For pedicle segmentation, it follows a very similar procedure as before of processing and another CNN, which we call CNN-head. Our data set description is there, and we also perform the same data augmentation as CNN-DB. All right, now iterative vertical location. So you saw from the previous two steps that we were segmenting on square images of the virtual body. But of course, we only have our initial k radiograph starts. And so we need some way to derive and crop these virtual body images to feed into the previous two networks. And so that's what this step accomplishes. So it starts by first estimating the starting vertebra, basically by cropping 5 images roughly 2/3 down the spinal column, indicated by the green dots here. And this is where the clearest vertebrae are typically present. That's why we chose this location. We crop and segment all 5 of those, and then we choose the best segmentation out of those 5 to use as our starting point. And to determine which one is the best, we use a derived similarity loss, script L, and I'll go over the details of that in the next slide. But just to finish off the rest of the step, we then estimate adjacent vertebra by using the current virtual body segmentation and the spinal column curve at that point, which is indicated by this pink line here. And so you see here that these green dots above and below that current segmentation is where we will crop and segment next. And from there, it's just iteration. So we iterate up and down to complete our segmentation until all of our relevant vertebral bodies are labeled. And so you can see in the rightmost image here that the vertebral bodies are now completely separated from the spinal column compared to on the left where it is still one continuous component. Right, and so I mentioned that loss. So the formula for it is here. I won't go over into the fine details of it here, but I will just build a general intuition for it. So L evaluates the quality of the segmentation, where the lower the value of L, the higher the quality of the vertebral body segmentation. And so what we have is a set of standard vertebral body masks, just very typical shapes you'd expect to see in a spine. And what we do is we take our predicted segmentation straight from CNN-DB and compare the minimum distances between the contours of the segmentation with each standard mask. So essentially what we're doing is we're trying to minimize the sum of distances between a standard mask contour and a segmentation contour pair. From this, we get the L, which is just related to the sum of minimum distances. And more importantly, we get the standard mask that reduced L, which you can interpret as the standard mask that is the most similar to our predicted segmentation. And with that, I can move on to image radiation correction. And so if you look at the image on the left here, you can see that in some cases, there can be an extra protrusion outside of the vertebral body that can really affect our AVR measurements. And so the idea here is that we have our standard mask that is the most similar to our segmentation. Let's use that by performing image registration using a scaling iterative closest points algorithm to align that standard mask with our segmentation. And then we can replace the registered mask, replace the segmentation with our registered mask. And so the result is that we now have a typical vertebral body shape. It's overlaid in the correct position on the X-ray, and we can now have more accurate AVR measurement by using this registered mask. And so with the vertebral body segmentation corrected, and we have our pedicle segmented, we can now use that information to calculate the Stokes AVR. Right, and so that was our algorithm. In terms of validating it, for segmentation, we perform 5-fold false validation for both CNN-SC and CNN-DB. And the metrics we report are precision, recall, and bias coefficients. In terms of AVR measurements, and this is perhaps more important because in the end, you are thinking of clinical feasibility here. We compared manual versus automatic measurements performed on a 26 image test set, which corresponded to 338 vertebra, and the manual measurements performed by a blind reader with over 20 years of experience. The metrics we report were percentage of measurements within clinical acceptance being defined as when the automatic measurement was within at most 5 degrees of the manual measurements. And we calculate the circular absolute errors between automatic manual measurement pairs and derive the mean and standard deviation from this distribution. And so moving on to results, you can see examples of segmentations for all 3 networks at the bottom here. And just summing up the table, we achieve a value of 0.91 for all 3 metrics in both class validations. But again, perhaps more importantly is our AVR measurement results. And so if you look in the first row here, we achieved 84% of measurements within clinical acceptance with a 3.1 degree circular mean absolute error, indicating high accuracy. And the measurement time per X-ray was 22 seconds, which corresponds to a 1.4 second measurement time per vertebra. And so this does improve upon the average 30 seconds it takes an experienced rater to manually measure one vertebra. And we also looked at the different performance related to the X-ray systems, and we saw a very similar performance, so not much to say there. And then I mentioned that we had a previous method that worked only on EOS X-ray. So how does our method compare with that? So we evaluated both methods on the same EOS test set using this paper, and we achieved a 6% increase in clinical acceptance, as well as a 1.4 degree improvement in ischemia. So we definitely see improvements in that regard. All right, and so here are examples of actual measurement outputs from our algorithm, with the red dots indicating the pedicles and the green dots, the red dots indicating the sensors and the green dots indicating the pedicles. And so this is really to illustrate that the clinician can easily look at this measurement outputs and decide on a snap judgment whether the measurement is valid or not, and decide whether to accept or tweak the adjustment if necessary. And so this really offers some interpretability that our algorithm has. All right, by conclusion, a fully automatic ABR measurement was developed that works on both X-ray systems, and it improves upon a previous method. And not only that, but there's hope for clinical feasibility there, with 84% of measurements within clinical error, so high accuracy, quick measurement time with a 1.4 second measurement time, and interpretable outputs. Here are the references. And with that, I'd like to thank you all for listening, as well as the funders, organizations, and people on the slide. And I'll be happy to take any of your questions. Thank you.
Thank you very much. Due to the time limit, we can only take one question. Any question? Yes, so maybe I would ask regarding the segmentation, how you can recognize the first vertebra when you start the segmentation on the left. I noticed that the cervical vertebra is usually on the present, as well as sacral.
Yeah.
So how you can ensure how many vertebrae to locate.
Right, yeah, that's a great question. So on the spinal column segmentation, actually, we specifically labeled only from T1 to L5. And we found that that actually really accurately located those vertebrae and only stopped the segmentations there. And so when we're doing this iterative vertebral location, basically we look at whether the spinal column is segmented at that region. And if it isn't, then we stop and we start iterating more downwards, basically.
So according to the distance between the vertebra and the